Hello, my name's Eileen Gowdy. The four of us are here today to tell you about our experience and journey to become more patient-focused in Island Health. We realize that the journey that we've been on and what we've learned will be relevant to many others. So what stood out for us in working to include the patient and family voice in care decisions? We thought this would be fairly straightforward because everybody believes that this is the right thing to do and that everybody is doing it. But our experience was not the case. We realized that this was not easy. And this is not easy because it was all about changing the culture within our organization.
You're right, Eileen. It isn't easy. And part of it is because we truly believe that we are already patient-centered. We're here for our patients, we're doing the right thing for our patients, but in reality, we're not meeting their expectations. When we look at literature, there's a confusion there about what actually is patient-centered care, and it's different from organization to organization. What is consistent, however, in literature is what the patients view as being patient-centered, and that's really us listening to them and taking a moment to ensure that we're doing what they want us to do. This whole myth of being patient-centered is something that we need to challenge, because when we look at our own performance and asked our own patients, we weren't meeting their expectations.
Yeah, so what we tried to do was understand what's behind that myth. And what we found is that we've developed a series of guidelines. We're very focused on efficiency, on quality care, on making sure that we've got task lists for people to follow to make sure that we're providing the very best care. So we become quite task focused. And through that, we're not involving patients in meaningful discussions about what's important to them, what their goals are, and who they are when they're at their very best. From patients and families, what we heard is that staff are very busy, and so they don't want to interrupt the staff and ask them questions or ask them for assistance. The patients don't feel like the staff really understand who they are or what's important to them. From the nurses, we heard that they don't think that they can provide the information that the patients need. They are very busy, and they're very concerned that they're not going to get through the list of things that they need to do in a given day. When patients are asking them questions, they worry that they're not allowed, that they don't have the permission to answer their questions. And so they sometimes become afraid to go into patients' rooms when they know that those patients or families are going to be asking those questions. And then from the physicians we heard, why aren't the nurses talking with the patients? And they just don't understand why the nurses don't feel like they can provide that information for their patients.
And when we shared what we learned with patients and staff and physicians, a seemingly simple solution of bedside rounding was considered and even endorsed to address those communication issues. When we looked at implementing that change, we were struck by the number of system changes that were required. The logistics were very complex. That simple solution was not so simple. And we as a research team, together with the staff and the frontline leaders, did not have the authority to make those changes. We also had the misfortune of poor timing. An urgent organizational imperative distracted our local leaders, and we lost momentum for the change. So our team regrouped. We looked at how we could affect change or leverage change differently or more strategically. Not that that was easy either.
So although we had tacit approval from our organization leadership to move this agenda forward, we really didn't have an obvious manifestation of that approval, and we really did not have the authority to make that change. So we thought that we needed to focus on developing an organizational strategy for patient experience and patient-centered care. We retooled our Patient Advisory Council to align with that strategy, and we worked to raise awareness within the organization for increased patient and family involvement at various levels. While at the same time, we worked to recruit additional patient advisors for involvement within the organization.
So the leadership expectation now is very clearly that patient-centered care will be provided, and we started on that journey. Patients and their families are now involved in selection committees for senior positions. They're involved in some of our quality committees, strategic planning committees, and they're even involved in the development of our electronic health record. And we're beginning to see an impact on some clinical processes.
You're right, Rita. I think we have started to make some good change. The leadership has signaled a change in direction to include patients. However, I think we're going to need a decade of really focused attention on being mindful of the patient experience, making sure that we are providing patient-centered care so we can find that sweet spot between standardized medicine and individualized medicine. We have a long way to go still.